जी ये फर्स्ट देखे लगा के देखे कलर वाला हुआ। हाँ जी good afternoon everyone. So I am back. Last time when we were back, I came, we discussed the easy part, which was the fluoroanatomy. Now we would be talking about sonoanatomy. The anatomy remains same. The only challenge it poses to us is because again a new technology comes in play. Therefore, the challenges are there. But if we are very clear with regards to anatomy, things can become very easy. So just to give you a brief, as I told in fluoro, I am repeat here, when we are doing intervention, specifically in the domain that we are, bone is our friend. That is one. Here we have one more enemy, if I may say so, that is a vessel. So whatever you are doing ultrasound guided, always have a bone at your base that yes, this is, or any structure around it, and always try to avoid any vessel. With regards to spinal pain, fluoroscopy is the gold standard. And why I say so? Because there is a direct visualization of the needle when even it goes below the bone. That is what you must have seen when we were doing those interventions. So for experts, you can do all those interventions under USG also, but the basic problem remains that once it goes below the bone, then the needle is not seen and it becomes more of a blind. That is one. And second thing is, as I said, wherever there is dye, there is going to be drug. So if you are not be able to push in the dye, you can never be sure about the position, which is just not possible with sonology. But some advantages. So what does that do is, for people, we know that radiation has its own set of side effects. Therefore, radiation exposure reduction is one big thing. And for most of the things clinically, what we are doing in a day-to-day practices, we are doing a hybrid technique. So what I will be doing is, I will be putting a needle under USG, and once I am sure about it, then I'll put in the dye and use fluoroscopy. Second, there is an increasing role, a lot of evidence is coming up for facial plane blocks in chronic pain. And now for that, the best drug, the best set of technology is definitely sonology. Then there are certain interventions where, for example, in cervical root, we talked a lot about it, that we should not do it under fluoroscopy, but that can again be done by USG guidance. Sometimes you can use for scanning also. Sometimes the muscle is something which I feel that you can definitely scan with great precision with sonology, so that is one. Secondly, somebody was asking about post-pregnancy. I would say there is a subset of patients who come up to us who are, during the pregnancy, they have back pains. In those, you cannot go for fluoro-guided intervention. Just in case if you have to, then definitely USG is the indication of choice. As I told you, what we can do, one, caudal epidural, with greater confidence we can do cervical selective root block. It was demonstrated. So again, it can be done. Cervical facet, lumbar median nerve block. SI joint is one thing. Another thing here is newer blocks for chronic pain is the plane blocks that I was talking about. Now, interestingly, when I talk about PRP, so again, the basic major subset of patients are non-specific low back pain, and in non-specific low back pain, there we can't find anything, and there they found out is that what happens is the erectile spinal group of muscles, or multifidus in particular, is the one which has atrophied, or that is weakness. So for that, we do exercise. Along with that, we can even consider doing a PRP in the muscle for its initiating its growth. So how do we scan? Now again, as regards to any sonology scanning, you need to follow a protocol. Again, we are converting a 3-dimensional structure into a 2-dimension. Therefore, you have to confirm anything in 2 dimensions always. So what we do is, one is a long axis, another is a short axis. So when we are doing a structure, we always go from long as well as a short axis. That is one. Third, something I always do is, I always have a 0. Means when you are doing things sonology under USG, you tend to get confused whether you are doing shoulder, whether you are doing hip, whether you do spine, because there are multiple layers. So always have that 0, and then you can start all over again. Now just imagine we are moving from lateral to medial. So if we go from lateral, we start moving, there is a group of muscles, and the first bony structure that we will encounter would be the transverse process. From transverse, we will be going to the facets, lamina, and the spine. Right? So for me, the 0, when I am doing a scanning of the ultrasound, is my transverse process. So bone is my friend. I see a bone, that is my 0, and then you can go medial or lateral, wherever you want to go. So medial, you will have facet, lamina, spinous process, where if you go lateral, you will have muscle layers. Until you reach the middle, and once you have done that, you can always have a short axis. So this is long, this is short axis. You can have at the spinal level as well as the interspinous level. So long axis view, we start with 3 muscle view, then 2 muscle, then for what we always call as then we come to the transverse process, facetal view, laminal view, and the spinous process. Now these are the images. So once you are at the transverse process, so again bone, hyperechoic, within a caustic shadow, it won't let anything go by. So you will get these straight lines. So this is a classical trident sign, which is for the transverse view. You move medially. So just imagine the anatomy. You are moving medially from transverse process. We have come on to the facets, facetal line, and there it becomes like a hump. So this is where the things starts to get interesting, because we are at the facet. So just in case if you are interested, you want to do a facet block, these are the facet blocks that you can consider going. That is one. Now from the facetal line, we are again moving medially, and what we get is a laminal view or the sawtooth appearance. Right? So this is a lamellar view. Now this is something, if you have not done sonology, it can be challenging. So the next view is, so in sonology what is actually happening is, I am throwing sound waves and I am again catching it. So even if I change the direction of the sound wave slightly, the image that I will get would be different. So so in this case, here I am just straight, where here I have not moved the needle, but I have just made it slightly oblique. Therefore, what I see is the dura. So dura, this is the posterior complex of the dura, and this is the anterior complex of the dura. So same place, just changing the direction of the probe, changing the direction of the sound waves being given and getting back. And then this is the short axis view. We are at the right at the spine. So we have the spine, we have the facets, and we have the transverse process. So again, this was something I said, you start from this, from 3-4 centimeters from the midline, you keep on going, you see the transverse process, and then you see the trident sign. You move still medially, you come at the level of the facets, you have the facetal thing. Then once we have the facets, then you move still medially, you come to the lamina. When you are in the lamina, you won't be able to see because there is an acoustic shadow. But the moment I change the direction of the sound waves, there you will be able to see these complexes. Excuse me. There you will be able to see the posterior and anterior complex where of that thecal sac. Again, this was this. So once the sound waves travel from the lamina, this is the anterior complex, this is the posterior complex, this is epidural space, this is your CSF. This is the short axis view, right on the spinous process, lamina, and the transverse process. Here, now from when I am at the spine, we just move little. and then what we get is the facet. So these slit-like openings on this is a facet. So if you are in a hurry, the patient is not able to tolerate that position, you do not have fluoroscopy. So this is something which I strongly recommend, is something that you can start doing, where you scan and do a facet block in the short axis view. Caudal epidural, again simple. You just start from the sacrum, just go down. So once you go down, you will see these beautiful cornuas, and between the cornuas, you will see the sacral hair. So we just need to introduce our needle right there. So this is a short axis view, this is long. So once we scan, we get the short axis view, we make it long, and that is how we, just 30 seconds, sir. So just we will SI joint again can be done, superficial joint. Now the other thing is the common, most common interventions that we are doing left, right and center, that is an erector spinal block. I won't go into the details. The simplest way is just hit the transverse process and give a lot of volume. So around 15-20 ml of local anesthetic can easily be given just by hitting the transverse process, and you will get a good spread, and the erector spinal block would happen. So this is the transverse process, so it can be given right from the thoracic to the lumbar region, and good for non-specific kind of low back pain. Just carry the message, limited lumbar spine intervention, definite role in facial planes, and for subset of patients and indications, you can definitely think about it. Thank you so much.
Thank you very much. Any question? I have a little comment. I don't know how many of you know.